And just to check in, Dr. Shuhart, could you just say something so you can see if you'll pop up on screen?
Okay.
Perfect. There you go. All right. Thank you so much. Okay.
Sure.
Everyone, I want to welcome Dr. Christopher Shuhart, who is the founder and director of the Bone Health and Osteoporosis Center at Swedish Medical Group in Seattle, Washington. He's past president of the International Society for Clinical Densitometry, and he's the co-author of that organization's publication of best practices in the Journal of Clinical Densitometry. Dr. Shuhart received his medical degree from Dartmouth Medical School in 1987 and his master's in health administration from the University of Washington in 2009. He's board certified in family medicine. He is also the physician who is treating my sister, Dr. Suzanne Holland. Dr. Shuhart, welcome to Bone Strong for Osteoporosis. It's an international community of people who are seeking effective treatment for their condition, primarily by using targeted exercise to strengthen their bones.
Thank you, Holly. My pleasure.
I'm going to just see if we can get a little bit more volume on that. Hold on a second. Let me see here.
I can turn up my microphone gain if you need, if that's what the
Yeah, a
issue.
little bit. It's just it's a little hard to hear you on
Right.
here.
Give me just a second.
Okay. The great backdrop. I hope to be there later in the summer.
It's gorgeous in the summer. Is that better?
Yes, people saying that they can hear you loud and clear. It may just be
Okay.
on my end. So thank you all for responding to
Yeah.
that. I thought we'd start right in on some questions. I know your time is valuable and greatly appreciate that you're here, which is about your Sunday afternoon. Can you tell us how you started to specialize in bone health?
Sure. It's a bit of a kind of a circuitous route, Holly. I'm a board certified family practice doctor, and for 15 years, I practiced full spectrum family medicine. I delivered babies for 15 years and assisted at surgery and got a great sort of broad experience in taking care of people, young and old. I came to work in bone health. It started all the way back in 1995, so I was a very young doctor at that time. And I worked on a quality improvement project inside of our medical group, an osteoporosis quality improvement project that I volunteered for. And something just clicked. For me, it was also the time when the first really potent and effective oral osteoporosis therapy, alendronate, hit the market. So it was kind of a nexus of forces. And that kind of started me down the path. In 2001, I got certified to read bone density through the International Society that you mentioned earlier. In 2007, I had been doing a fair amount of consultation for my colleagues inside the medical group. And I thought that maybe for the second half of my career, I could do this full time. And it's really with the good graces of many, many people who taught me so much on the job and not on the job, colleagues around the country and literally around the world, that I got to open the Osteoporosis Center in 2010 and have been doing it ever since.
It's fascinating. We talked a little bit earlier through text too of how much there is a willingness of people to share within the field.
It's really a fantastic collegial community. It's small. We all know each other, or we are 1 degree removed from knowing someone. And that's also great for when patients move to other places, even other countries, and want to make sure that they get the best that they can for their bone health. That I can usually find someone for them or find someone who knows someone.
It's very encouraging. We're glad you're part of us tonight. How have you changed your approach to treatment over the years, and why?
I think a lot of what's changed for me is the recognition that first, there are patients who have osteoporosis who actually are not at high risk for fracture. And it's very plain to see that when we utilize fracture risk calculation systems for patients. Likewise, I think it's become quite clear to me and hopefully to your audience that there are patients without osteoporosis who are at high risk for fracture. And being able to delineate those groups of patients has been very important change. I think we've seen in the last 10 to 15 years kind of a dawn of new approaches to treatment. And I think more and more we're looking at the kind of the bigger picture, not just treating people with medications, but understanding things like dietary importance of dietary intake, protein, not just calcium and vitamin D, but a protein intake, exercise. I think we're going to spend a fair amount of time talking about today, and support for fall risk reduction. I think all those things, the older I get, the more I appreciate those kind of things as well.
I appreciate that you spoke about those nuances, and I want to pin that for just a second, but I wondered if you could go into a little bit more depth about the fall risk and how that determines treatment, or you just explain a little bit more about that variation.
Right. So I think most of us who do this consider falls what we call an extraskeletal risk factor for breaking, right? Osteoporosis treatment medication doesn't influence that yet. There have been some attempts at, for instance, improving muscle mass with medical treatment, at least in non-clinical models, and they haven't been terribly successful. But understanding a patient's fall risk and trying to mitigate future falls is critical. Falls are opportunities to break. And for instance, patients with certain neurological disorders, pick one, multiple sclerosis. In general, very generally speaking, patients with MS are twice as likely to break at any given bone density than patients who don't have MS. And some of that has to do with maybe their previous treatment, but a lot of it has to do with the fact that they may fall more, and when they fall, they may be more likely to injure themselves. So there are ways to reduce fall risk. It takes a little bit of discussion and help from the team, including physical therapy and sometimes visiting nursing, et cetera. But we make every effort to find people who are at high risk, whether they know it or not, and mitigate that risk.
Great. Let's talk. We're going to go to some of the diet and exercise issues as well, but tell me, what do you look at when prescribing one medication over another? I mean, what is your general approach?
Well, Holly, the first thing I look at is severity. So there is a distinction between a patient who has osteoporosis based on bone density and, for instance, a patient who has osteoporosis and a compression fracture. Those patients have a more severe problem and probably require more intensive treatment. So that's the first thing that I consider. Is the patient a severe osteoporosis patient or not? Then I look at a whole host of things. What's the patient's underlying medical status? What are the ongoing medical problems? What is the likelihood that a patient will be able to tolerate a given medication, knowing the potential for some minor and perhaps even more serious side effects? Those are rare. And then looking at getting down to some very practical things, right? The best medications that we have can sometimes be unaffordable for patients. And that's, in some cases, I consider it criminal. But we have to consider the practicalities as well when we think about prescribing.
What is the most important information that you wish all doctors would share with patients when they're seeking treatment for osteoporosis?
That we can make people stronger, that we can make them better, and we can make them better without toxicity or with minimal risk of toxicity. I think that there's a lot of urban myth, medical myth, if you will, even with doctors, that osteoporosis therapy is toxic, that it causes people to break more, that it's difficult to tolerate. And that's just really not the case. I do think that if we can spread the message that we can rejuvenate the skeleton, it's one of the few tissues that can do that. We can bring it back a bit, so to speak. Many patients come in to see us, and their only hope is that they don't get worse. And when I tell them that they can get better, they find it sometimes hard to believe, but it's very clear that they can.
I really love that terminology, rejuvenate the skeleton. I'm gonna have to use that myself sometime. But it makes me think of those as a owner of a Pilates and yoga studio. How many clients have come in and said that when their physician first told them they had osteoporosis and they say, "What do I do?" The doctors said only, "Watch that you don't fall." And I think that goes back to your, whatever you do, don't fall. That you're looking at something more broadly, but that may not be the norm.
Right. That's something that I hear very commonly. Just, you have osteoporosis now, you have to be careful. You can't ski anymore. You can't pick up your grandchildren anymore. These are the things I hear once a week, twice a week. Someone will say to me, I can't do this anymore, right? And the answer is, well, the data really don't support that, except in cases where, modification of lifestyle is important, where people have manifest fragility. But in most cases, we shouldn't, and we need to encourage people to be more vigorous, not less vigorous.
Yes, I love that expression too. Okay, let's go back to a little bit to the protein versus calcium idea, because I think most people have an understanding that you need to supplement your diet with calcium when that has some risks of its own. But let's look at the nutritional aspects.
Sure. Well, I want to make it clear, it's protein and calcium. It's not either or. And so the three the macro and micronutrients that I look at with patients, so of course, calcium and vitamin D, to a lesser extent, the potential for vitamin K supplementation, even though the data regarding its benefits are really quite meager. It's probably not harmful, and biologically, there's every reason to believe that there's plausibility that vitamin K should help. But then when it comes to protein, and particularly as people get older, this idea of sarcopenia, that word may have come up for you with other speakers or in other times, the idea of loss of muscle mass and muscle power, and replacement of muscle by fat. The notion here is that the more muscle you have, the better off you're going to be. And if you want to maintain muscle, particularly if you decide to exercise, you have to consume enough protein. And I find many patients, particularly those over 70, are not consuming enough protein.
So what is your discussion with your clients about exercise and osteoporosis?
Well, the discussion really centers around understanding that if you want to make your bones even a small bit stronger, and that's really what the data tell us, is that we're seeing incremental changes in, for instance, bone mineral density. If you want to do that, you have to overload your musculoskeletal system. So walking as an exercise is fantastic for your cardiovascular health, but it's probably not going to do much for your osteoporosis. It's certainly better than sitting on the couch, but it's not better than being in your Pilates studio or at home on a Pilates mat or a community exercise class. So I talk to patients about overloading ever so slightly their musculoskeletal system on a regular basis, combining strength, flexibility, and balance. And telling them that the use of exercise may impart some small benefit to for instance, their bone density. It has never been shown to, in a clinical sense, lower the risk for fractures. But it provides so many other benefits, including lowering the chances of falling, injuries when people fall, recovery from falls so that people don't injure themselves as seriously, that it stands well on its 2 feet, for as an example, to help patients with osteoporosis.
Let's talk about osteoporosis medications in general. Are the drugs today truly better, or are they just better advertised?
There's only 2 countries that advertise direct to consumer, right? And interestingly, the other one is New Zealand. No, they're not actually better advertised. There's only, I think, one medication right now that has, for instance, airwaves and online advertising. No, they are better. They are more precisely targeted. They work with mechanisms that are more broadly beneficial to bone. So, for instance, as a prototypical medication, Fosamax works to slow down the activity of bone breakdown cells. It turns down bone metabolism, bone turnover. That's one way to improve the strength of bones. You allow more calcium to enter existing bone tissue. You don't generate any new bone tissue. There are therapies, some of them older, like a medication, teriparatide's been around for 22 years, that stimulate new bone formation. Its newer cousin, abaloparatide, has been around for about 10 years. And the newest medication, called romosozumab, is kind of the holy grail biologically. It stimulates new bone formation at the same time that it suppresses old bone reabsorption and results in very rapid improvement in bone strength and very rapid lowering of risk for fractures.
And what is the name that's known by?
Romosozumab?
Yes.
That's called Evenity.
Evenity. Okay, thank you.
Yes.
I want to go back to each of those individually, but I wanted to stay with just kind of help people understand a little bit. What kind of medication journey should a patient with osteoporosis expect today? Because some of the medications you can't stay on for very long. Can you speak a little bit about that?
So I want to make sure that I stress that the idea that a medication has a limited lifetime, a duration of therapy that cannot be exceeded, is not one that is medically sound. That, for instance, medications like Fosamax, it's very common to hear patients and healthcare providers say, well, you can't take that medicine for more than 5 years. And that's actually just not the case. It may not provide much additional benefit after 5 years. And since there are other medications that can provide additional benefit, it's an opportunity to take a look at another treatment if you are still at high enough risk that you need ongoing treatment. And that underscores the idea that osteoporosis is a chronic medical problem. It's analogous to high blood pressure. I have high blood pressure. I take blood pressure medication. Hypertension has not been scratched off of my problem list. My blood pressure is at target, and if I stop taking my medicine, my high blood pressure will return. Ultimately, patients who take osteoporosis therapy, some of them may be able to temporarily stop their treatment and coast on the accumulated medication in their bone mineral. But ultimately, that effect will go away and their osteoporosis will recur. And they will need treatment again because they'll be older at that point, and age is an important determinant of fracture risk.
Sorry, go ahead, please.
No, please.
Well, I just, when you talked about the nuances of the 5 years, for example, which is typically thought of with Prolia. So is it just that research hasn't gone beyond that period of time to see a benefit, or that it just stopped being beneficial after 5 years?
Yeah, just for clarity, Prolia, you mentioned Prolia. Prolia, we have to be very careful about stopping Prolia. Bad things happen when we stop Prolia abruptly. So for any of your audience out there on Prolia or thinking about Prolia, It's very important that they and their healthcare providers understand that. Um, the nuances are such that certain medications have been shown to be beneficial for more than 5 years in certain circumstances. But you're right, every patient's circumstance is a little bit different. So if you happen to fit into the box of the 5 years on Fosamax study data, then it's possible that an additional 5 years of Fosamax could be beneficial for you in certain circumstances. We don't have a lot of data for extending medications. So we have some data for the IV medication called Reclast, which is zoledronic acid. We have data showing effectiveness to maintain bone density for 9 years of use with that medication. We do have some extension studies for all the other medications, but we don't have a lot of data beyond the duration of the clinical trials for the medications. And every medication is a little bit different in the duration of its clinical trials.
We go back a little bit and talk about, before we get into the specific medications, the process for those who may not understand of what happens after menopause, typically when the balance of osteoblasts, which build bone, and the osteoclasts, which chomp away at it, if you will. Can you talk a little bit about that?
Sure. So to understand this, it's important to understand the life cycle of the skeleton. When we're born, we have very little calcium in our bones. And interestingly, the bone density of a 10-year-old is about the same as the bone density of a 90-year-old. But of course, 10-year-olds don't break nearly as often and they fall a lot. So it has to do with something else, the resilience of the bone that they have. We have all the bone we will ever have, very generally speaking, by the time we're at age 25. And if everything goes well and you do all the right things, you will maintain that bone density for about 15 years. And then starting at 40, for all of us, for an unknown reason or reasons, we start to lose bone density. We call that age-related bone loss, and that continues throughout our lifetimes until we die. At menopause, estrogen deficiency accelerates bone loss because of the effect of estrogen on bone metabolism. When estrogen is removed at menopause, osteoclasts, those chomping cells that you talked about, become more active, relatively speaking, with respect to the bone forming cells. That leads to net loss of bone strength. And for instance, for 5 or 7 years, it's possible to lose 3 times as much bone in menopause as you were losing in age-related bone loss before you got to menopause. So it's quite substantial. It's very easy to lose 15 or sometimes even 20% of your bone mass in 10 years, starting 2 years before your periods stop and then going forward 10 years.
That's really remarkable. I'm glad you spoke of it that way, because I think that's the shock factor that so many people get, that it has declined so precipitously.
Right. And it's not common to do bone density before menopause. So there's no way to know for many women exactly how much is lost, right? But we do know that, starting in 2002, healthcare providers and patients ran away wholesale from hormone therapy based on the WHI study in 2002. And we know that there's nothing like hormone therapy to maintain bone density and bone strength and keep fracture risk down in that menopausal transition. We're finally starting to see the pendulum swing back a little bit, I think, and we're seeing more patients considering or being put on hormone therapy.
I'm glad you mentioned that as well. And I definitely know that's something that's been a huge benefit to me. Let's now talk about some of the specific medications. The bisphosphonates, I am not good at pronunciation. The key medication here is alendronate.
That's correct. Fosamax generic, yeah.
Which then does target the osteoclast and doesn't let them take as much calcium and break down the bone as much.
Yeah, it's pretty straightforward. That when it comes right down to it, Fosamax and its cousins are designed to kill osteoclasts. They are overactive and overabundant, and it's designed to keep their numbers down so that the bone recycling mechanism comes back into balance.
And so that's the problem, is that it's somewhat indiscriminate, which is called necrosis with the jaw.
Actually, osteonecrosis probably doesn't have anything to do with the impact on osteoclasts. We're not exactly sure what the issue is there. Osteonecrosis is a disorder of disruption of blood flow. It's a bone death that occurs when blood flow is disrupted, microvascular blood flow to an area of jawbone. So that is not about osteoclast. Doesn't appear to be about osteoclast injury or death when it comes to treatment with medications like that. And remember, because that's such a rare disorder, if every person who takes Fosamax, for instance, just to pick on Fosamax, will have their osteoclast disrupted. Yet it might be 1 in 10,000 people who take oral medication who actually develops osteonecrosis. So it's something clearly not related to osteoclast, and because it's so uncommon, it has to do with patient factors, that some of which we're aware of and some of which we're not aware of.
Why is it generally considered the first line of treatment for osteoporosis for many people?
Well, there's lots of reasons. 1, it's got a 30-year track record. 2, it's now dirt cheap. 3, it's effective. It lowers the risk of spinal fractures by about 70 or 75%. It lowers the risk of hip fractures by about 50%. Now, it's not 100%, but it's pretty good. You'd be going to Vegas much more often if you were 50% more lucky. And it's very, despite what your audience and you may know, it's extremely well tolerated. There are some people who probably shouldn't take it. There are people who get side effects. The side effects are mostly upper GI side effects as the common class of, and about 20% of people will say have some sort of upper GI complaint. We have other choices for them.
And we've talked about my question about the number of years you can stay on these medications. Is there generally an amount of time that it's considered effective and not?
Yeah. So when it comes to, let's stay with Fosamax for a minute. The initial clinical trials for Fosamax, there were 2 of them. They lasted for 3 years. So when we tell patients that we can reduce their risk of fracture 70% at the spine and 50% at the hip, that's on 3 years of use. Okay. We have data for Fosamax with a relatively large extension trial showing us that 5 and even 10 years of use is effective at maintaining bone density and at perhaps lowering the risk of what we call clinical spinal fractures for extending the dose. Really, the issue about limiting the duration of therapy for the medication, in my mind, is so that we can reassess risk and use better medication if the patient is still at high risk. If the patient's not at high risk, then those are people who can go on that planned interruption that you may have heard about called a holiday with monitoring. And what they're doing is they're coasting on the residual medication in their bones that's still quite active and may be active for a number of years after they stop.
And how does a patient monitor that? I mean, especially if you're seeing an internist, for example, who really this isn't your specialty. What kind of questions, what kind of approach should someone take?
Well, hopefully it's up to the provider, right? If the provider is contemplating putting someone on a quote unquote holiday, the provider, I would hope, understands that osteoporosis is an ongoing medical problem, right? And that at some point, the holiday will end. The way that it's generally monitored or recommended to be monitored is with bone density. The residual effect of the medication can, when that residual effect starts to wear off, that can start to be manifest in a decline in bone density. Another way is with what's called bone turnover markers. I don't know if you have any familiarity with those, but those are biological molecules that, that are in the blood and urine that can also be valuable, understanding the kind of relative impact on biology of the residual medication in the bones.
There was a question just now, is reclassed the same as Fosamax?
It's not the same, but it's in the same family. So it is a bisphosphonate. It's an intravenous bisphosphonate, and reclassed for osteoporosis is given once a year.
Let's talk a little bit about the selective estrogen receptor modulators. This is the Vista. It binds to the osteoclasts, which reduces their ability to remove them. Describe it in relation to Fosamax.
So we'll call it SERMs. We'll say SERM, right? SERMs, raloxifene, actually bind to estrogen receptors. They are selective estrogen receptor modifiers. And it is the downstream effect of the estrogen receptor on osteoclasts that does the work. So they do limit osteoclast numbers, like all antiresorptives. They limit osteoclast function and longevity. They're relatively modest anti-osteoporosis agents. Raloxifene lowers the risk for spinal fractures when given for osteoporosis. It does not lower the risk for hip fractures, however, and that's, I think, an important distinguishing fact. There are sometimes other reasons to use raloxifene, particularly those who might be at high risk for developing breast cancer. Those have had specific types of abnormal breast biopsies. It can be as effective as, and we know it is effective, as the standard medication tamoxifen for preventing the progression of a precancerous biopsy to breast cancer. So sometimes there's a 2-for-1 effect in certain patients. It isn't considered to be protective against breast cancer in all comers. Sometimes patients will relate that they've heard that, but that's not what the science would tell us.
You just mentioned the hip versus the spine, for example. Can you speak a little bit more of that? There was a question in relation to the best medication for the hip, say, for example, versus the spine.
Yeah, so all clinical trials in the United States and frankly around the world right now have certain endpoints to prove so that the medications can be licensed, and those are fracture endpoints. And the typical fractures that we look at in osteoporosis are spine fractures, hip fractures, not spine, not hip fractures, or not spine fractures. That would include hip, okay? Increasingly, we get spine and non-spine, but back in the old days, we would get trials that had hip fracture, spine fracture, and not hip, not spine. Almost all medications that we give lower risk for hip and spine fractures, except for raloxifene. And the medication called ibandronate or Boniva also did not demonstrate effectiveness for hip fracture reduction in its clinical trials.
Oh, yeah, I remember Sally Field used to advertise that one.
Exactly, yes.
A lot. Let's go back a little bit to Prolia. This also addresses the osteoclasts. And I'm not sure why maybe it's just a categorization that I wasn't able to clarify in relation to those others we talked about.
It is unto itself. That's why. Yeah. So the category for denosumab is that it is a modifier of a receptor on osteoclasts, but it is a fake binding agent. It's a protein. It's a fake binding agent for that receptor, which is called RANK, R-A-N-K. It's the only medication in the class. It's a very potent antiresorptive. It's the most potent osteoclast inhibiting agent that we have. It can do a very nice job improving bone density and lowering risk for fractures. But it does have this issue that we've known now for about 7-8 years, that if it is discontinued, particularly after long-term use, rapid bone loss will result, and rapidly rising risk for spinal fractures can result. So I think many of us who use a lot of it had seen during the pandemic, particularly early on, people were staying away from getting their shots. They didn't want to go into healthcare facilities to get their injections. I saw lots of people lose bone and lose a fair amount of bone. So I'm using it less and less for new patients, except in very particular circumstances where I feel like I need a boost in bone density relatively quickly, and then I may transition to something like Fosamax after a year. The other thing about Prolia is that it cannot be, other medications cannot be terribly effectively sequenced after it. Sequencing is one of these things that we do now in osteoporosis care. We give one medication and then another medication to get added effect. Certain of our other medications simply cannot be sequenced behind Prolia, and that makes future care challenging.
And some of those include?
For instance, Forteo and Tymlos, the PTH analog medications, some of the bone building medications, if they are sequenced behind Prolia, we know very clearly from a decent sized randomized controlled trial, people will lose bone density. And that's a double shame, right? They lose bone density and they've made an investment usually in these self-injected prescription medications. Even with coverage, they're probably paying a fair amount of money and they're not getting any value for it. So we have to be very vigilant about that.
Well, I really like the clarification that you're giving on all of this. And I know it's really just the chat board is going kind of big on this right now. Tell us a little bit more about the anabolic drugs. You just mentioned Tymlos and Forteo. What is their success rate? They're more recent, correct?
Well, Forteo's been available since 2002, and this really points out something, Holly, that I'd like to stress, in that we don't use these treatments often enough. We don't recognize the patients who should get them first. I think, spending a lot of time in primary care before I came to bone health, I still see that there are patients who are sort of automatically treated with Fosamax when their bone density is in the range of osteoporosis, with or without a fracture. And so that notion of severe osteoporosis that I mentioned earlier is one that's important to consider, because those severe osteoporosis patients can benefit more from having medicines like Forteo or Tymlos first, if we can get those approved, because we're not only putting more calcium into the bone structure, we are repairing the degraded bone structure that is part of osteoporosis. And as I said earlier, sort of rejuvenating the microstructure of bones and putting more material into it with medicines like Forteo and Tymlos, and actually Evenity that we talked about earlier.
And how do you sequence those? Are there patterns you have to avoid?
Well, there are patterns you should certainly follow, right? Any of those three medications they have no lasting effect. There's no reservoir of medication in the bone mineral. So those medications must always be followed by some sort of anti-resorptive therapy, one of the bisphosphonates or Prolia, so that we can sort of metaphorically put our arms around all the new bone that we've generated with those medications. It's critical. Otherwise, for instance, if you take Forteo for 2 years and someone says, oh, you're good, 2 years later, you'll have lost everything you gained. And you'll have had injected yourself every day for 2 years and maybe spent a fair amount of money out of pocket on coinsurance for your prescription, and it will all be for naught. So it's always sequenced that way. That's a favorable sequence, right? Is to use an anabolic first, followed by an anti-resorptive.
I really like the way you speak in metaphor. As a former journalist, this story aspect here is really good. Can you talk about some of the side effects of those medications?
Sure. So those medications, Forteo and Tymlos are analogs. They're closely related to uh, the body's natural calcium controlling hormone called parathyroid hormone, or another related protein called PTHRP. So they are analogs of parathyroid hormone and PTHRP, respectively. They work at the PTH receptor, the parathyroid hormone receptor, and that is present on the surface of bone forming cells, and to a lesser extent on osteocytes, which are bone kind of orchestrating cells. They stimulate the activity of bone forming cells to lay down new bone tissue, so you get more bone versus no more bone with Fosamax and Prolia. You get brand new bone that then becomes mineralized. When we give these medications, bones actually get larger. You can't feel it. We can't measure it with a bone density machine, but the diameter of long bones increases by maybe 1% or 2%. It doesn't sound like a lot, but the physics tells us that when we take a pipe and we make it ever so slightly bigger in diameter, we make it much more resistant to bending. So these medications are very important and need to be used more often in assessing and treating osteoporosis patients.
But in general, cost is the big deterrent.
In general, cost and pre-authorization, right? So the first hurdle is that many insurance companies, let's say if you're a Medicare beneficiary and you have a Part D Delta drug plan, many insurance companies will have a prerequisite. In other words, you won't be deemed worthy for the medication unless you've already taken Fosamax for 3 years, right? In certain circumstances, when we stress that a patient has severe osteoporosis, we may be able to get those medications approved. So approval's one thing, coverage is another thing. In other words, almost all of these medications, because they're specialty prescriptions, they are going to require out-of-pocket expense. Now, the manufacturers of Forteo and Tymlos have some great, even Forteo, now that it's gone generic, the manufacturer of the name brand still has a great customer support system. And I have lots of patients who are getting free drug from their manufacturers, but that there's an income test for that, and that's not available to everybody for certain.
A question about the likelihood of osteosarcoma with Forteo.
Certainly, it's a common question that comes up, and I'll say straight away, osteosarcoma with Forteo and Tymlos is not a human problem. It's a rat problem. It's very clear now why rats are and were susceptible to primary bone, osteosarcoma is primary bone cancer. It's not metastatic. It arises in the bones primarily. It is an extremely rare adult disease. 1 in 150,000 adults, 20 times more common in children, unfortunately. So the issue here is that rats in the preclinical studies for Forteo clearly developed bone cancer. We now know why they do and we don't. And it took unlocking the genome of us and the rat to figure it out. For Forteo, the boxed warning for osteosarcoma has been removed. It is now a standard warning. It was removed in 2020, even though we had data for at least 10 years that showed that there was no increased risk for osteosarcoma in people. The box warning for Tymlos is still present. Tymlos has only been around for a little less than 10 years. I have no doubt that it will be removed at some time as well. I tell patients that we need to have respect for this, but we also need to know that 20 years of follow-on mandated by the FDA tells us that this does not happen in people, and that the 1 in 200,000 risk that might be doubled or tripled if it were real. When you put that up against the math of more spine fractures and hip fractures, it just doesn't make any sense. I understand the fear, but people should be much more afraid of what happens to their lives after they break their hip.
Can you address a little bit about osteopenia? Because many people are in this category and are still finding medical professionals who are recommending medication. What do you
Right.
say?
I have osteopenia too. And I would tell patients it's not a disease. It is simply a description of a range of bone densities. The most important thing about bone density that's not in the range of osteoporosis is what's the risk for fractures, right? So as I said at the beginning, some patients with osteopenia or low bone mass are at high risk for fracture. And that typically would depend on factors about them other than their age, height, weight, bone density, sex, race. It depends on their medical problems, and it depends on the medications that they take. It depends on their previous fracture history. So those three factors can influence the risk in a patient with osteopenia to the point where the patient would be considered at high risk for fracture and would be recommended treatment. We do know that we can slow down osteopenic bone loss by giving medicines like Fosamax. And in fact, there is a dosage for prevention of osteoporosis with a number of osteoporosis medications for those with osteopenia. But I like to think about fracture risk. And so it's really rare for me to prescribe medication, except in the relatively newly postmenopausal woman who comes to me and says, I don't want to be like my grandmother. I want to do everything that I can to hold on to the bone that I have. And so that's a case where someone with osteopenia comes and says, I want prevention, and they're newly menopausal, and that would be an ideal place to use hormone therapy if it's deemed safe.
I wonder if was there anything else that you specifically wanted to address before I get into some of the questions that have been posed?
I want to make sure that for your listeners out there live and forever who else may listen to this down the road, is that this idea of severe osteoporosis is a really important one. If you have an osteoporosis level bone density and you have a spine or hip fracture, or even a pelvic fracture, or an upper arm fracture, or maybe you've had two fractures, you had a pelvic fracture and a wrist fracture, it's likely you have severe osteoporosis. And severe osteoporosis is something that really should not be waited on. It shouldn't be, it needs to be approached aggressively, because the skeleton is telling us things about its strength that a bone density just is not telling us. And that's the second thing. I think we're invested in bone density. We really haven't talked much about it here, which is fantastic. Bone density doesn't tell the whole story, and fractures tell sometimes a much more important story. So I want people to pay attention to fractures. I want doctors and other healthcare providers to pay attention to fractures.
And what resources would you point to for people to understand that more?
Yeah. So the resource that I point to frequently for my patients is the Bone Health and Osteoporosis Foundation, formerly the National Osteoporosis Foundation. This is a patient-centered organization. It is a professional organization, but it's patient-centered and patient-focused. So it is at Bone Health and Osteoporosis, one word, all mashed up, .org. Fantastic resources at that website that span the gamut from the medications to exercise to diet to balance to advice for professionals. I really encourage people to utilize that website if they have access to it.
Great. I'll turn to a couple of questions that were submitted to the form we had in here. I think we've addressed this a little bit, but maybe you could just touch on it again, when you should consider medications as opposed to only eating for nutrients and weight training. Want to be smart, but trying to avoid medications and side effects.
Sure. Well, again, I have 10 medications that I prescribe all day, every day for 15 years. If these medications were terribly toxic, I wouldn't have a job. They're not. I think it's important to understand the goal of osteoporosis therapy is to lower the risk for fracture. And as I stated earlier, if someone is deemed at high fracture risk, we really don't have any data to support the fact that diet and exercise alone are going to substantially lower their fracture risk. So it's important to understand that there is a role for treatment, and that you might think about working a deal with your healthcare provider, right? You work on your plan or a plan together that does not include medication and set some goals, right? If the goal is, I'd like to see your bone density go up, because if it doesn't go down, your fracture risk is still going up, right? Because you get older, your fracture risk goes up. So I'd like to see patients and healthcare providers get into that mode of saying, well, we can try this for a while, but I'm concerned that your fracture risk is high enough that if we don't get where we want to go, we really have to take a closer look at taking treatment.
So the natural question that came from that was, are you available to treat people outside of Seattle?
Certainly, I have people come, from a distance to see me. Right now, unfortunately, my practice is closed to. I have a huge backlog right now, and we don't have any other providers in the clinic. It's me. The challenge is that I can't do any new patient virtual assessments because I can't put my hands on people, and even if I could, there's a licensure issue for virtual visits. So right now it's hard to be able to say yes to those people. There are other people who do what I do around. And as I said, it's a very sort of small collegial group. And if someone, for instance, wants to send you a message and says, ask Dr. Shuhart if he knows somebody in X, then that's something I'd be willing to entertain.
Thank you. Yeah, I think that's a great follow-up to that. I just want to go back to Prolia. There was a question about the quality of bone density gained is not the same as healthy bone, and one can still fracture. What are your thoughts on this?
One can always still fracture. So I think there's this idea that osteoporosis therapy, whether it's particularly anti-resorptive therapy, Fosamax or Prolia or cousins, create inferior bone. That's simply not the case. If I take a slice of vertebral bone, it would hurt. But if I took one from someone who took Prolia and someone who didn't take Prolia, and I gave them to a pathologist and I said, tell me the Prolia patient, they can't do that. They can't distinguish the bone with routine and microscopy. They can't distinguish that. So we know that patients who take Prolia and all osteoporosis therapies have fewer fractures, substantially fewer broken bones. If the bone was bad or got worse, we should see more fractures. We simply don't see that.
Are there any drugs that are coming in the market in the near future that you're excited about?
Unfortunately, no. There's nothing in the pipeline right now. I don't see anything in the next 3 to 5 years. Eventually, osteoporosis doesn't get a lot of research money. Our clinical we've got one bright spot, and the bright spot is that there is a move to alter the way that we do osteoporosis clinical trials. As I told you before, in the past, we've had to demonstrate that we lower the chances of fractures. There's enough evidence now that improving bone density is a good surrogate that professional organizations in the United States are starting the process of petitioning the FDA to change the way that we do osteoporosis therapy, osteoporosis clinical trials, so that we could accomplish them in less time. If there's less time, it costs less money. If it costs less money, there's more likely that the market will open up for even smaller players or molecules that, for instance, were once thought to not have as much promise. So that is the good news on the horizon, but there's nothing else right now in the pipeline clinically.
It's discouraging to
It
see.
is.
Let's see. I know there's someone who wants to know if you know anyone in Denver, perhaps if folks
I
could.
do.
Okay, yeah, go ahead, please.
The people in Denver at CU, Dr. Christine Swanson and Dr. Nicole Rothman, both excellent endocrinologists there. There is a gentleman, Dr. Paul Miller, who is world-renowned. He has his own clinic. I think he's in Aurora now, but I wouldn't be surprised if he's going to retire soon. But there's some names right there in Denver.
Great. I'll just take one more because I want to give you every city in the country, but San Francisco.
Okay. Yeah, San Francisco, there are a couple of people. Last name is Wu. I want to say Joan or Joyce, but if you email me, Holly, get the participants' information. Ellen. No, okay. There is definitely someone in San Francisco.
So those who are participating or those who will be listening to the replay, if you will email me the areas where you need a doctor, and only if you need one, if you're seeing somebody, I don't want to overwhelm Dr. Shuhart. I'll try to put that in a group message so he's not responding to that over and over again. But I can understand why people are interested, and you have such a vast knowledge and approach. Let's see, I think we've addressed most of these tonight. And thanks for Lawrence. We don't have anybody in Paris yet, but I'll try to get yours in there.
I do have somebody in Paris.
And she stayed on all night and it's very late there.
Oh, I see.
What about Paris?
So I know someone in Israel who will know someone in Paris. So okay. I can figure that out.
All right, excellent. So I'll put together, folks. The chat doesn't always last for me. So if you might just send me a bonestrongforosteoporosis@gmail.com. I'll try to put together a list so Dr. Shuhart can answer that. And I just want to thank you so much for this such informative discussion tonight. And I know your time is very valuable, but I feel like we all learned so much that we can now share and follow up on too. Any last words from you that you'd like to share? No, it's been a pleasure, Holly. Thank you so much. And thanks to Suzanne for offering me up. Yes. I see her there. Hi, Suzanne. And I just looked it up while it is Dr. Joy Wu at Stanford. In San Francisco. For the Bay Area people. Great. Okay. And we will make this replay available. I'll also provide it to Dr. Shuhart. So if you want us to share that with people, to spread his knowledge around a little bit so you don't work yourself to death. Again, I'm Holly Holland, and I'm founder of the Bone Strong for Osteoporosis program. And I thank you so much for being here, everyone. And Dr. Shuhart, most gracious of you. Thank you for inviting me home. Good night. Good night.